Hi everyone, this is Dr. Sakshi Arora Hans. Now I just want you to show me a thumbs up if I am audible and visible to all of you. Quickly just show me a thumbs up. Manoj, Deepak, please if you can let me know whether I am audible and visible to all of you. Okay, thank you Himani. Yeah, right. So I am not going to waste your time. This session is very important for your upcoming INICET exam and for NEET PG 2023. All the FMG students who are watching this session, you may also note down these updates. Some of these updates I will also be covering in the sessions which I am going to take for you. Now, just to make things easier for you, I will be quickly covering these updates because there are around 50 slides which I have to cover. I want all of you to keep on taking screenshots. This video is going to be available even after the session is over. In between, I am not going to look at the chat box because I want to first cover these updates and then I'm going to take up your queries. So please don't keep on posting your queries. In between the session, I am not going to take up. Now, in this session, we will be covering the most important algorithms. So your case in the form of 20 case discussions. These 20 case discussions are very important. After these 20 case discussions, there are 4 or 5 updates which I want to give you all. All those who are Marrow subscribers and who have gone through edition 6 of Marrow or who have gone through the MCQ discussion and revisions of edition 6, you don't need to watch this session. The only update, the new update which you don't know, which I will be covering in this session, is the new semen analysis parameters. So, and the Lakshya. So Lakshya and WHO's new semen analysis parameters. These are 5 updates which I'm going to be covering at the end of the session. So all the Marrow subscribers, you can just, once this video is there, after the session is over, you can look at the last 10 to 15 minutes of the session. That is something new for you. Rest everything I have covered. Right? Okay, so case number 1, a G2P1 female who is pregnant. She's complaining of bleeding at 32 weeks of pregnancy, and if they ask you what is the next step, now they have not told you whether the patient is suffering from placenta previa or she is a case of abruption. Just if they give you this much and they ask you what is the next step, please remember, whenever a female comes to you with bleeding, next step or the first step is resuscitation. Resuscitation has to be done with 2 large bore IV cannulas. All of us know that there is number 14 cannula and number 16. These are large bore IV cannulas. Now they can interlink your clinical surgical knowledge over here. They can ask you what is the color of number 14 cannula. So the color of number 14 cannula is orange, and number 16, it is grey in color. When you are putting the cannulas, you are going to take out samples, give IV fluids, give oxygen by mask, and maintain airway, breathing and circulation. Once you have done this, then the next step in the algorithm is to note whether the vitals of your patient are stable or not. And while you are noting this, you are also going to concentrate on the history and per abdominal examination, and based on history and per abdominal examination, mentally you are going to see whether you are dealing with placenta previa or abruptio. Now, it doesn't matter whether you are dealing with placenta previa or abruptio if the vitals of your patient are unstable, or if there is, so even after initial resuscitation, if vitals remain unstable, if there is fetal distress, instead of writing fetal distress in your questions, it can be written as category 3 CTG findings. Whenever you get this term category 3 CTG findings, automatically that means that is a case of fetal distress. It is very important for all of you to know what are the findings which are included in category 3 CTG findings. In category 3 CTG findings, number 1, they can give you that the patient is having sinusoidal pattern. The baby on CTG, you are getting a sinusoidal pattern. Number 2, they can give you absent beat to beat variability along with bradycardia, absent beat to beat variability along with persistent variable decelerations, or absent beat to beat variability along with late decelerations. So if they give you any of these findings, number 1, sinusoidal heart rate pattern, number 2, absent beat to beat variability with bradycardia, number 3, absent beat to beat variability with persistent variable decelerations, or absent beat to beat variability with late decelerations, that automatically means they are talking about fetal distress. Or if in the question you are getting DIC, any of these 3 things are mentioned and they ask you what is the next step. Next step is immediate cesarean section. You are not going to say I'm going to do an ultrasound. Ultrasound is not needed, whether it is placenta previa, whether it is abruptio. If you are getting any of these 3 findings, next step is immediate cesarean section. Now if your question is talking about fetal death, please remember, fetal death is seen in cases of abruptio. Fetal death is generally not associated with placenta previa. So if they say fetal death is present, then in the question go back and see whether the vitals of the patient are unstable or vitals of the patient are stable. If vitals of the patient are unstable and there is fetal death, then the next step again is cesarean section. But if vitals of the patient are stable and there is fetal death, in this case your answer is going to be, the next step is going to be induction of labor. That is how questions are being asked these days in NEET and in INICET. You are going to get clinical questions where they are going to ask you the next step. Right, this is if you are getting vitals of the patient unstable, fetal distress, DIC, or if you are getting fetal death in the question. Now suppose your question is a patient has come to you with antepartum hemorrhage and patient had bleeding after initial resuscitation, vitals of the patient are stable, and they ask you the next step. Now the next step is you are going to do a transabdominal scan. A transabdominal scan, that is a screening test. Please do not say that I'm going to do a TBS, although TBS is the investigation of choice for placenta previa. But if vitals of the patient are stable and they ask you next step is going to be a transabdominal scan, which is a screening test. In this transabdominal scan, you are going to see whether the placenta is in lower uterine segment or whether the placenta is in upper uterine segment. If placenta is in lower uterine segment, then that means I'm dealing with placenta previa. In that case, my next step becomes the investigation of choice, that is TVS. In case the placenta is an upper uterine segment, or if your question is saying there is a retroplacental clot or retroplacental hematoma, or if your question is saying gel O sign is positive. Right, what is gel O sign? That is something new which has come. Gel O sign is shimmering of the placenta, which is seen with the movement of the mother or with the movement of the transducer. Gel O sign is seen in case of abruptio placenta. That's very, very important. So if any of these 3 things is given, it means you are dealing with abruptio placenta. If it is a case of abruptio placenta, then I don't need to do a TVS, right? Please remember, abruptio placenta is a clinical diagnosis, right? And in case of abruptio placenta, per vaginal examination is not contraindicated. You can do a per vaginal examination after ruling out placenta previa. That's very, very important. Right, now this is the way you are going to manage if it is a case of question comes that a female has come to you with antepartum hemorrhage. Antepartum hemorrhage is any bleeding which is happening beyond 28 weeks of pregnancy. Please remember that in the recent classification, we do not divide placenta previa into type 1, type 2, type 3 or type 4. Now we divide it into only 2 categories, placenta previa and low-lying placenta. Low-lying placenta is when the placental edge is within 2 centimeters of the internal os, but it is not touching or covering the internal os. If the placenta touches or covers the internal os, then that is placenta previa. This is the new classification. We do not say type 1, type 2, type 3, type 4 anymore. Right, so this is case number 1 where they are talking about antepartum hemorrhage. They are not telling you abruptio, they are not telling you placenta previa. If you understood case number 1, just quickly show me a thumbs up. I'm just waiting for your thumbs up if you've understood case number 1. We are then going to do a second case related to antepartum hemorrhage, that is case number 2. right? Now, in case number 2, we have, I'm just waiting for your thumbs up. If I see a thumbs up, immediately I'll go to the next case. Great. Thank you, Dr. Himani. Seni, Icons, Lakshmi. Okay, great. Coming to case number 2. Now, if you are nursing student and you are here, this is a little more update for you. Wait, I am going to give you updates related to your level, right? So don't feel offended, but this is a little too much update for you. So it's better that you watch those sessions which I bring out specifically for nursing, or those sessions which I bring out for FMG students, right? Okay. Coming to case number 2. Case number 2 is a G2P1 woman at 20 weeks. She undergoes a target scan and patient has placenta previa as an incidental finding. There is no complaint of bleeding, no fetal anomaly. Now, so many times you are going to see that in first trimester or in second trimester, you are going to get a low-lying placenta. Patient doesn't have any bleeding, and all of you know that for a diagnosis of placenta previa, the diagnosis is made in third trimester. But then in such cases, what am I going to do? In such cases, please remember, in 90% of the cases, when I'm going to do an ultrasound in third trimester, I will see that the placental migration has occurred. In 10% cases, when I will do ultrasound in third trimester, it will still be a case of placenta previa. Now, in this case, if they ask me what is the next step as an incidental finding in second trimester scan, I have got placenta previa. The next step is you have to advise your patient. You have to advise your patient to avoid sexual activity, to avoid heavy weight lifting, to avoid moderate to severe exercise, and to avoid standing for more than 4 hours. And then you are going to tell your patient that she is going to get her ultrasound done at 32 weeks pregnancy and 36 weeks of pregnancy. The investigation of choice is TVS. And at 32 weeks and 36 weeks, when I'm doing a placenta, if I see that the placenta has gone in the upper uterine segment, then I will continue with the routine antenatal visits. And if I see that it is a low-lying placenta or it is a case of placenta previa, then I am going to schedule a cesarean section, and this cesarean section will be scheduled somewhere between 36 to 37 weeks. So around 36 to 37 weeks, if the placenta persists, so she will come to me 32 weeks, she's going to come to me at 36 weeks, and after a week, that is around 37 weeks, I am going to schedule a cesarean section. So you will do a cesarean section at 37 weeks of pregnancy. Right? Okay. Coming to case number 3. Case number 3 now is a known case of placenta previa, and she has come to you with bleeding PV. Please remember that in placenta previa, per vaginal examination is contraindicated, per speculum examination is contraindicated. Now, if they ask you next step, you will have to see what other findings are given to you, because next step can be active management, next step can be expectant management. Active management means that I'm going to go for immediate cesarean section. Right? And active management I'm going to do when patient is hemodynamically unstable, when there is persistent bleeding, if patient is in labor, or if I'm getting category 3 CTG findings, or this is something which I want all of you to highlight and remember. This is a new indication which has come in Williams, and this is if there is significant blood loss has happened and gestational age is more than equal to 34 weeks. So if significant blood loss has happened and gestational age is more than equal to 34 weeks, then I'm going to take up my patient immediately for cesarean section. Expectant management is McAfee and Johnson regime, and I'm sure all of you know what are the steps for McAfee and Johnson regime. What are the indications for doing expectant management? Number 1, if patient is stable. Number 2, there shouldn't be any active bleeding. There shouldn't be any fetal distress. Either gestational age is less than 34 weeks, and all patients with gestational age less than 34 weeks, I have to do expectant management. If gestational age is more than equal to 34 weeks, then I am going to do expectant management only and only if there is no significant blood loss, right? So till edition 5, till earlier editions, we were taking the landmark as 37 weeks. Now it is 34 weeks. At more than 34 weeks, if significant blood loss has happened, go for active management. At more than 34 weeks, if significant blood loss hasn't happened, go for expectant management. That is McAfee and Johnson regime. Rest, Dr. Rahul, FMGs can watch this session. Clear? Have you all understood the algorithms for managing APH, that is placenta previa, and abruptio? Placenta previa is basically abruptio. Now I'm going to tell you. So suppose your case number 4. Case number 4, suppose they give you a question that there is a G2P1 pregnant female who has come to you at 34 weeks. Her BP is 150 by 110 and patient is having pain in abdomen and bleeding PV. Now because she's a case of PIH, because she has pain in abdomen and bleeding PV, I'm taking her as a case of abruptio. Now if they ask me what is the next step, my next step is going to depend upon what conditions are given to me other than this in the question. If any emergency condition is mentioned in the question, for example, if your question says there is fetal distress, there is DIC, maternal vitals are unstable, or mother has acute kidney injury or acute kidney disease, in this case, I'm not going to wait. I'm going to go for immediate cesarean section in case of abruptio. In case of abruptio, as I told you previously, if they mention fetal death has happened, then you have to see whether the vitals of the patient are unstable or vitals of the patient are stable. If vitals of the patient are unstable, go for cesarean section if fetal death has happened. If vitals are stable and fetal death has happened, go for induction of labor. Now again, there is an update over here. Earlier we used to say that whenever there is DIC, you shouldn't be doing cesarean section. Whenever DIC is present, correct DIC followed by vaginal delivery. Now the latest edition of Williams says that if DIC is mentioned in the question, then in that case you have to correct DIC followed by cesarean section. So this is a very important update. If you are not a Marrow subscriber, please make a note of this. Right? Now, maternal condition, if your question is saying maternal condition is stable and there is no emergency condition, again, there is an update for all those who are not Marrow subscribers. All Marrow subscribers, you know all these updates already. So, if maternal condition is stable and there is no emergency condition, the update is that now for abruptio also you can go for expectant management. Till this time, till earlier, till previous edition of Williams, every time it was said that if there is abruptio, you have to go for induction of labor. But now they say that if vitals of the mother are stable and there is no emergency condition, you have to look at the gestational age. If gestational age is less than 34 weeks, you are going to go for expectant management of abruptio in the line which is similar to placenta previa. The only difference is when you do expectant management of placenta previa, if uterine contractions are present, you give tocolytics, right? Now, there are two tocolytics which are not given to patients of placenta previa. I'm very sure all the Marrow subscribers would be knowing this. I have taught you. Tell me what are the two tocolytics which are not given to patients of placenta previa. Quickly in the comment box, write and tell me. Okay, so there is some lag. I'll be wasting time waiting for all of you to write in the comment box. So remember, two tocolytics which are not given to patients of placenta previa are terbutaline and endomethacin. As far as abruptio is concerned, in patients of abruptio, we never give them any tocolytics, even if we are doing expectant management. Right? The other thing is, if this over here you cannot see, what I have written over here is if gestational age is more than equal to 34 weeks, then you are going to go for induction of labor. So in case of placenta previa, always you go for cesarean section. In case of abruptio, it depends upon if it is an emergency condition, cesarean section. If it is fetal death along with mother's vitals unstable, cesarean section. If it is fetal death but mother's vitals are stable, and if there is no emergency condition and gestational age is more than equal to 34 weeks, you go for induction of labor. Right? So that is how you manage a case of abruptio. This is the fourth very important case which you need to know for your NEET PG exam and for your upcoming INICET exam. Right? Then, a next very important case is regarding Bishop score calculation. This is a very, very important table which is given in Williams, which I have taught you in Marrow also, in revision videos also, in MCQ discussions also, and in main videos also. Very important for all NEET students and INICET students to know how the Bishop score is calculated. Now, there is a lot of confusion with all of you regarding what is the optimum score. Please understand, I have written exact lines from page 488 of 26th edition of Williams. 26th edition of Williams says that if score in Bishop score it is more than 8, then that conveys high chances of induction of labor being successful. And if score is less than equal to 6, that is an unfavorable score, right? In Bishop score, if you remember, all the Marrow subscribers, I have told you the mnemonic. Delhi police employed special commandos, where D stands for dilatation of the cervix, P stands for position of the cervix, E stands for effacement of the cervix, S stands for station of fetal head, and C stands for consistency of the cervix. Now, as far as the score is concerned, for dilatation, effacement and station, maximum score can go up till 3, whereas for consistency and position, maximum score goes up till 2. So overall Bishop score maximum can be 13, right? This is normal Bishop score. Now then there is a modified Bishop score. In modified Bishop score, effacement has been replaced by length. So calculation of Bishop score is very, very important. This is a very important table for upcoming INICET exam. Similarly, this table over here, which is related to the agents which are used for induction of labor. Now, all these agents are given and the dosages are given here. I have straight away taken a screenshot from Williams for this table so that there is no confusion at all. Now, all of you know that the best drug for induction of labor is prostaglandin E2, that is dinoproston gel, which is Serviprim gel. Now, these days, this gel is available in the form of a device or an insert, and that is called as Servidil insert. So, all those who have given INICET mock test, you would have seen an image of Servidil insert also in one of the mock tests, and they had asked you that what is the total amount of PGE2 which is contained in this Servidil. So the total amount of dinoproston or PGE2 which is present in Servidil is 10 milligrams, whereas in Serviprim gel, which is commonly used in your labor rooms, it is 0.5 mg. Serviprim can be repeated after every 6 hours and maximum you can give up till 3 doses. Please remember a few important points related to Servidil. Now, when should Servidil, be given, for how much time patient should remain recumbent after taking Servidil, after inserting Servidil. So Williams says that patient has to be recumbent for at least 2 hours after you have inserted Servidil. When should Servidil be removed? Servidil should be removed after 12 hours, or it should be removed as soon as the process of labor begins with the onset of labor, or it should be removed at least 30 minutes before the administration of oxytocin. So these are two very important points on Servidil. Then other important points on the insert or the Servidil is that Servidil, Williams says it should be used with caution in females with ruptured membranes, in females with glaucoma, asthma, CPD, unexplained vaginal deliveries, unexplained vaginal bleeding, and more than equal to 6 prior term pregnancies, right? So in these conditions, Servidil or this dinoproston insert, it has to be used carefully. Now, there is one more thing which the new edition of Williams says, what are the factors for successful induction of labor? So the factors which are associated with successful induction of labor are: number 1, young age of the patient; number 2, if patient is multiparous, then the chances of induction of labor are high; number 3, if BMI is less than 30. So you cannot see less than 30 over there, I'm writing it here. BMI less than 30, that is associated with increased chances of successfulness of induction of labor. Favorable cervix and birth weight less than 3.5 kg. So if birth weight of the baby is less than 3.5 kg, then these are 5 factors which are associated with increased success of induction of labor. Very, very important points for upcoming INICET exam. So I want all those students who are preparing for INICET and NEET PG to take a screenshot of this table and keep it with you. There has to be a question on either biophysical score or Bishop score or WHO's scoring system for molar pregnancy. Out of these 3 scores, biophysical score, Bishop score and WHO's scoring system for GTN, most of the times you get one question, right? So these three scores are very, very important as far as OBS is concerned, right? Then comes case number 6. Case number 6 is a 34 weeks primary female at 11 p.m. reports in labor room with decreased fetal movement, and they ask you the next step. So next step in this case, the best answer is going to be a modified biophysical score. Please remember, you are not going to answer NST unless and until modified biophysical score is not given. If modified biophysical score is given, your answer is going to be modified biophysical score. In modified biophysical score, which is a screening test, there are only two parameters at which you look. Number one, you look for AFI. Number two, you look for NST, right? And if any of these two parameters is abnormal, you go to the diagnostic test, and the diagnostic test is biophysical score. Now, in NST, you are going to do an NST for 20 minutes, and in 20 minutes, if you are getting 2 or more than 2 accelerations, that means it is a reactive NST. And if they ask you the next step is you will send the patient back home. Just want to ask whether all of your lectures are from Williams. Yes, all of my lectures are from Williams. Okay, so please just now don't write in the comment box. It is going to interrupt my flow and your flow as well. Okay. So in NST, if you are getting 2 or more than 2 accelerations in 20 minutes, that means it's a reactive NST. And in a case of reactive NST, the next step is send the patient back home. Now, if you are getting less than 2 accelerations, you all know that you have to repeat NST for 20 more minutes. That means if you are getting less than 2 accelerations in 40 minutes, then that is a non-reactive NST. And whenever there is a non-reactive NST, what is the next step? Next step is biophysical score. How do you define accelerations? An acceleration is defined as 15 increase in heart rate by 15 breaths per minute for 15 seconds at more than equal to 32 weeks. If you are doing NST before 32 weeks, then it is 10 beats per minute for 10 seconds. So increase in heart rate by 10 beats per minute for 10 seconds, that is acceleration. Now, according to ACOG 2021, a very, very important update which has come, if you are getting accelerations on NST strip, irrespective of fetal movement, you are going to take it as an acceleration, right? So the moment you get an acceleration, irrespective of whether fetal movement has occurred or not, you are going to take it as an acceleration, right? Then false negative NST. False negative NST means if you are getting a false reactive NST. So a false reactive NST rate is very less. It is 0.2 to 0.8%, and most common cause of death in these cases is meconium aspirations. Then what is the interval which should be there in between NST testing? So in all conditions where mother's condition is stable, for example, if it is a case of pre-gestational diabetes, it is a case of chronic hypertension, it is a case of lupus, in all these cases, you have to repeat NST weekly. Then if it is a high-risk pregnancy, for example, it is a case of preeclampsia, severe preeclampsia, it is a case of polyhydramnios, it is a case of IUGR. In all these cases, you have to repeat it twice weekly, or you may also do it daily. That depends, varies from condition patient to patient and condition to condition, right? Now, once you get a non-reactive NST, I told you the next step is biophysical score or a Manning score, and all of you know what are the parameters to be included in biophysical score. It is TB, meningitis, always notorious. So, biophysical score is very, very important. Now, more important than the definition of the score and the, what are the parameters which are included in the score is the interpretation of the score. So, for your NEET exam, for your INICET exam, you should know the interpretation and what is the next step when you have what you have to do. So if the score is coming as 10 by 10 or 8 by 10 and amniotic fluid volume is normal, right? In that case, you are going to say it is a normal biophysical score, and the next step is repeat the test weekly, right? Now, if score is coming as 6 by 10 and amniotic fluid volume is normal, in this case, it is called as an equivocal score. And in case of equivocal score, the next step depends upon the gestational age. If gestational age is more than equal to 37 weeks at a score of 6 by 10, you have to deliver the patient. And if it is less than 37 weeks, then you have to repeat the test in 24 hours. You cannot see it there. I am writing it here. you have to repeat the test in 24 hours. Now suppose the score is 8 by 10 or 6 by 10, but this is with decreased amniotic fluid volume. So when you are doing amniotic fluid volume, in case of modified biophysical score, you go for AFI. In case of biophysical score, you have to look at the single largest vertical pocket. So if the score is coming as 8 by 10 or it is coming as 6 by 10 with decreased amniotic fluid volume, they ask you what is the next step. Next step is you have to deliver the patient at more than equal to 36 weeks. Clear to all of you? Now, if score is coming as 4 by 10, you have to deliver your patient at more than equal to 32 weeks. If score is coming as 2 by 10 or 0 by 10, immediate delivery. Very, very important for your upcoming INICET interpretation of the biophysical score. Right? Now, case number 7. Case number 7 is a suspected fetal growth restriction case. Now, in a case of fetal growth restriction, the Doppler which you are going to do in order to know the prognosis of your patient of the patient is umbilical artery Doppler. Along with umbilical artery Doppler, you are going to do ultrasounds, which is going to be a serial ultrasound in order to know the fetal growth as well as to know amniotic fluid. Because commonly fetal growth restriction is associated with oligohydramnios. You are going to tell me in the comment box one condition, which is that one condition in which fetal growth restriction is associated with polyhydramnios. I want to see answers. If you are a Marrow subscriber, I have taught you one condition where fetal growth restriction is associated with polyhydramnios. Once the session ends, in the comment box, you are going to write it for me. Right? Okay. So you are going to do serial ultrasounds, you are going to do umbilical artery Doppler, and you are going to do fetal surveillance. So in all high risk pregnancies, please remember you have to do fetal surveillance, whether it is diabetes, whether it is PIH, whether it is oligohydramnios, whether it is fetal growth restriction. Now then your answer is going to depend upon management of IUGR, depends upon what they have given to you regarding umbilical artery Doppler. Umbilical artery Doppler images are also very important, and umbilical artery Doppler as such for what is the next step is also very important. Now, if they say that there is fetal growth restriction and there is normal umbilical artery Doppler, the umbilical artery Doppler studies are normal, then you are going to say that I simply have to keep my patient under surveillance. So I will repeat umbilical artery Doppler weekly, I will do NST weekly, and I will do ultrasounds every 3 weeks. And if on ultrasound oligohydramnios is present, I will deliver the patient between 36 to 37 weeks. If there is no oligohydramnios, then it depends upon the estimated fetal weight. If estimated fetal weight is between 3 to 9 percentile, you are going to deliver your patient between 38 to 39 weeks. And if estimated fetal weight is given as less than 3 percentile, you are going to deliver your patient at 37 weeks. This is very important for upcoming INICET exam. For your NEET exam, you simply have to remember if oligohydramnios is present, the time of delivery is 36 to 37 weeks. That's very important. And if there is no oligohydramnios, then you have to deliver if estimated fetal weight is less than 3 percentile at 37 weeks, if estimated fetal weight is between 3 to 9 percentile, 38 to 39 weeks. So anytime beyond 37 weeks, you have to deliver if there is no oligohydramnios. If oligohydramnios is present, you have to deliver between 36 to 37 weeks. Exact timelines are important for upcoming INICET exams. Right? Now, for oligohydramnios or for IUGR, the mode of delivery is vaginal delivery. This is if you were getting normal umbilical artery Doppler. This is a very, very important table which has been given in Williams. You cannot afford to miss it. Now, if they say umbilical artery Doppler with increased SD ratio. Now, if SD ratio is increased, that means patient is going towards PIH. And all of you know that if it is a case of mild PIH, you have to deliver at 37 weeks. Now, if it is umbilical artery Doppler with absent end diastolic flow or umbilical artery Doppler with reversed end diastolic flow, Now, this is a very important update. Abhi tak we were studying that if there is absent end diastolic flow, you have to deliver the patient at 34 weeks. Now, the new edition of Williams says between 33 to 34 weeks. And if there is reversed end diastolic flow, we used to say that termination of pregnancy has to be done at 32 weeks. Now they say it has to be done between 30 to 32 weeks. Very, very important update. So what if your question comes that there is umbilical absent and diastolic flow and gestational age is less than 33 to 34 weeks. So if there is absent end diastolic flow and gestational age is less than 33 to 34 weeks, or if there is reversed end diastolic flow and gestational age is less than 30 to 32 weeks, very, very oftenly asked questions in your NEET and INICET. In that case, you are going to hospitalize your patient, you are going to give her corticosteroids, you are going to do NST 1 to 2 times in a day, umbilical artery Doppler you are going to do 2 to 3 times in a week, and ultrasound you are going to do every 3 weeks. So ultrasound you are going to do every 3 weeks and umbilical artery Doppler every 2 to 3 times in a week. Clear to all of you? Very, very important table of Williams, which I have made it in a simplified format for you for your upcoming INICET exam. Please take a screenshot and keep this with you. Now, the next important topic on which they ask you the management part and the algorithm part which you have to know is for Atonic PPH. This is again a very, very important algorithm. Now, whenever you have a patient of Atonic PPH, the first step is you have to give uterine massage. Please remember, uterine massage is no longer a part of active management of third stage of labor. Now it is a part of treatment of labor, treatment of PPH. So you are going to do uterine massage plus you are going to give uterotonic drugs, and this you are going to continue for 30 minutes. Now the first line uterotonic which you have to give in PPH is oxytocin. The dose of oxytocin is 20 international units which you have to give in the form of IV infusion or IM. Remember that oxytocin is never given IV bolus, because if you give oxytocin IV bolus it can lead to bradycardia or it can lead to cardiac arrest. Similarly, whenever you are preparing IV infusion of oxytocin, you should always prepare it in electrolyte rich media like normal saline or ringer lactate. You should never do it in dextrose 5%. This is because this can lead to water intoxication. Right? Now, the second line drugs which are recommended by WHO for treatment of PPH is methylergometrin 0.2 mg, which you can repeat after every 20 to 40 minutes for a maximum of 5 doses. The best drug or the drug of choice for treating PPH is carboprost, which is also called as dinoprost or hembate. The dose of carboprost is 250 micrograms, which can be repeated after 15 to 90 minutes. Very, very important. Maximum you can give it up till 5 doses and maximum you can give up till 2 milligrams. Now, the side effect of dinoprost or carboprost is diarrhea. It is contraindicated in asthma. That is, you always remember. But two things which you forget is that it is also contraindicated in patients of pulmonary hypertension and amniotic fluid embolism. The alternative drug which you can give is mesoprost. The dose of mesoprost for treating PPH is 800 micrograms sublingual or orally. Now, this is the dose which is recommended by WHO. The recent guidelines say you can give 600 to 800 micrograms. Right? Now, per rectally is not recommended by WHO. Per rectally is recommended by ACOG. And if you are giving it by per rectal route, you can give up till 1000 micrograms. ACOG says that the dose of mesoprost for treating PPH is between 600 to 1000 micrograms. WHO में अगर एक आंसर मार्क करना है that what is the dose of mesoprost recommended by WHO for treating PPH, undoubtedly you are going to mark 800 micrograms as the answer. Right? Now, along with that, WHO says you can give tranexamic acid. Tranexamic acid 1 gram should be given within 3 hours of onset of PPH, and it should be given in a slow IV format. Now, suppose your question says that you have given oxytocin and they ask you, you've given oxytocin and methylergometrin and they ask you the next step. And in the options, you have both carboprost and mesoprost. Please mark the answer as carboprost. Remember, mesoprost is a drug which has equal efficacy or lesser efficacy than oxytocin. So if oxytocin cannot stop the bleeding, then mesoprost also cannot stop the bleeding. The other important update is recently WHO has recommended that to all rural females, whenever they come for antenatal visit, you should, in the antenatal visit only, you should give them mesoprost. They should be having mesoprost at the time of the delivery, so that just in case they start bleeding more, they can insert it they can take it orally, or they can take it sublingually, or they can insert it per vaginally or per rectally. Right now, the drug which is not used for active management of third stage of labor is carboprost. Carboprost is a drug which is used, recommended by WHO for treatment of PPH and not for active management of third stage of labor, that is not for prevention of PPH. A drug which is not recommended by WHO for management of PPH but you were using it in active management of third stage of labor is carbetocin. Carbetocin is a synthetic oxytocin which was recommended for active management of third stage of labor, which is recommended for active management of third stage of labor by WHO, but it is not recommended for treatment of PPH. What is the dose of carbetocin? Very, very important for active management of third stage of labor. It is 100 micrograms, right? So these are the important points which you have to remember as far as drug management of PPH is concerned. First thing is you have to do a uterine massage and you have to give uterotonics for 30 minutes. If in 30 minutes the bleeding is not controlled, then the next step is mechanical compression. For mechanical compression, you are going to use a Bakri balloon catheter. Most of the times we use a Bakri balloon catheter. The alternative is you can use an SB esophageal catheter, or you can use a condom catheter. Maximum capacity of Bakri balloon catheter is 500 ml, and if bleeding stops, after how many hours are you going to remove the Bakri balloon catheter? You are going to remove it after 12 hours. Now, even if after mechanical compression bleeding doesn't stop, then what is the next step? The next step is compression sutures. The most commonly applied compression sutures are B-link sutures. The other sutures which can be applied are Heyman, Gunshella and Cho square sutures. If bleeding still continues after applying B-link sutures, you are going to go for devascularization surgeries. In devascularization surgery, the first artery which you are going to ligate will be a uterine artery. So you are going to go for a bilateral uterine artery ligation, and then you are going to ligate ovarian artery. And if bleeding is still continuing, then the next step is, in your question, see whether the vitals of the patient given are stable or vitals given are unstable. Most of the times by this time vitals of the patient would be unstable, and if vitals of the patient are unstable, my next step will not be internal iliac artery ligation. My next step is going to be subtotal hysterectomy or supracervical hysterectomy. Only if question mentions that the vitals of the patient are stable, then my next step is going to be bilateral ligation of the anterior division of the internal iliac artery. Right? So, and if this fails, then automatically I go to subtotal hysterectomy. Now, after subtotal hysterectomy, also if your patient continues to bleed, then in that case I am going to apply pelvic pressure packs. Pelvic pressure packs, these are umbrella pack and parachute pack. Umbrella and parachute pack. Clear to all of you? So please show me a thumbs up if you have understood PPH, the algorithm for PPH. Then I'll come to the next case. And that is a very, very important case which is being asked these days in your INICET exam, in your fmge and in your NEET exams. And that is a case of postpartum collapse. Last year in 2022, in your INICET also there was a question on postpartum collapse. In your NEET also there was a question on postpartum collapse. And in your fmge exam also there was a question on postpartum collapse. Right? Now, postpartum collapse, if you get a question, there are three differential diagnoses which should come to your mind. Either you are dealing with a case of PPH, or you are dealing with a case of uterine inversion, or you are dealing with a case of amniotic fluid embolism. There are other reasons for postpartum collapse like uterine rupture, but then these are the three most common ones which should come to your mind. Now, in case of PPH, please remember that is the most common cause of postpartum collapse, and when you are going to do a per abdominal examination, and because most of the times it is a case of atonic PPH, you are going to get a soft uterus, or the uterus, the fundus of the uterus will be soft or it will be relaxed. In case of traumatic PPH, fundus will be firm and it will be felt just below the umbilicus. So this is the per abdominal finding which you are going to get in a case of PPH. In atonic PPH, fundus will be soft and relaxed. In case of traumatic PPH, fundus will be firm and it will be felt just below the umbilicus. On per vaginal examination, there is going to be excessive blood loss. So the question is typically going to say that excessive blood loss was present. Now, the other reason, and everything about PPH you already know. Now, then the other reason for postpartum collapse could be uterine inversion. Please remember, uterine inversion is the most common cause of immediate shock after delivery. So, if your question says that a female goes into shock immediately after delivery, you should think about uterine inversion. This immediate shock is because of neurogenic shock. Like later on, it is followed by hemorrhagic shock and death of the patient occurs due to hemorrhagic shock. But first, जो immediate shock मिलता है, that is because of neurogenic shock. Now, on per abdominal examination, your question is going to tell you that you can feel a cup-like depression below the umbilicus because of the inversion of the fundus. And on per vaginal examination, they are going to say a globular mass is felt inside the vagina. Then comes amniotic fluid embolism. These days they are asking questions on amniotic fluid embolism. In amniotic fluid embolism, you are going to get sudden death or sudden shock within 30 minutes of delivery. Per abdominal, everything will be normal. Per vaginal, everything will be normal. A little more details which you need to know over here are about uterine inversion and about amniotic fluid embolism. Now, in uterine inversion, as I told you, on per abdominal examination, your question is going to say that you are getting a cup-like depression just below the umbilicus. On per vaginal examination, there is a globular mass felt inside the vagina. Question is going to say that patient goes into shock immediately after delivery. The most common cause of uterine inversion is mismanaged third stage of labor. You pulled the cord and the placenta was not yet detached. That leads to uterine inversion. Now, what is the management algorithm for uterine inversion? Uterine inversion is an obstetrical emergency where you have to resuscitate the patient and you have to call for help. Number 2 step is stop oxytocin and then attempt manual replacement of the uterus, which is called as Johnson's method. At this point of time, I will not try to separate the placenta. I will just stop the oxytocin, let the uterus be relaxed, and I will try to manually reposit the uterus without trying to separate the placenta. Right? Now, if this fails, then I'm going to give a uterine relaxant and again I am going to attempt manual replacement of the uterus, and if that also fails, then I am going to do surgery. The abdominal surgery which you do for uterine inversion is Huntington method, and if a constriction ring is present, then you have to do a vaginal surgery which is called as Haltane surgery. Right? Sudden and immediate में difference कैसे पता लगेगा? So sudden and immediate में यहाँ पे question अभी I am telling you, in uterine inversion, per abdominal and per vaginal findings will be very different from amniotic fluid embolism findings, right? यहाँ पे question में sudden लिखा होगा या immediate word भी लिखा हो सकता है, but per abdominal and per vaginal findings are going to be different. यहाँ in amniotic fluid embolism, the death is going to happen within 30 minutes of delivery, and in case of uterine inversion, patient is going to go into shock immediately after delivery, right? You just listen to me for amniotic fluid embolism. I am just going to tell you the criteria for amniotic fluid embolism and you will understand that, right? Okay. Now, when you have done replacement by any of these methods, once the uterus has been replaced by any of these methods, you are going to stop the tocolytic, you are going to remove the placenta, you are going to start a uterotonic to prevent reinversion. Right? So then you are going to, once you've done this much, stop the tocolytic, whichever tocolytic or uterine relaxant you were giving, remove the placenta and then restart with a uterotonic so that reinversion doesn't happen. Clear? This is the management algorithm for uterine inversion which you have to remember. All these are consecutive next step, and next step, and that is how question is going to be asked. Coming to amniotic fluid embolism, very important topic and upcoming topic for NEET, INICET and FMG exam. As I told you, in case of amniotic fluid embolism, the embolism is going to happen at the time of labor or within 30 minutes of labor. In amniotic fluid embolism, there are 2 phases. In the first phase, patient is going to have cardiac and respiratory failure. So always in your questions, they are going to say patient went into shock and there is some kind of difficulty in breathing. So whenever you get this word difficulty in breathing, it should always ring the bell and take you towards amniotic fluid embolism as your diagnosis. So cardiac and respiratory failure happen in the first phase of bleeding. In first phase of bleeding, in first phase of the shock, in first phase of amniotic fluid embolism, bleeding is less. Then comes the second phase of amniotic fluid embolism. If patient survives this first phase, then comes the second phase, and in second phase DIC happens, because of which there is going to be excessive bleeding. The diagnostic criteria for amniotic fluid embolism, which has been given in Williams, you shouldn't be knowing that. So there is unexplained shock with very less bleeding in amniotic fluid embolism. Clinical onset is going to happen within 30 minutes of labor or during labor. There is an abrupt cardiorespiratory arrest. Na to in uterine inversion you get respiratory arrest. Difficulty in breathing, you never get in uterine inversion. Difficulty in breathing, you never get in PPH. This difficulty in breathing you get in case of amniotic fluid embolism. Overt DIC and no fever. This is the diagnostic criteria for amniotic fluid embolism. So whenever your question says that there is unexplained shock plus difficulty in bleeding plus less bleeding, so unexplained shock plus difficulty in breathing plus less bleeding, then also you have to think about amniotic fluid embolism. Or suppose your question says there is unexplained shock plus difficulty in breathing plus excessive bleeding, then also please think about amniotic fluid embolism. Why in excessive bleeding I'm thinking about amniotic fluid embolism? Because this means that the patient has survived the first phase and has gone into the second phase where DIC has happened, right? So do not say that I am making a diagnosis of amniotic fluid embolism based on less bleeding or more bleeding. Diagnosis of amniotic fluid embolism is based on involvement of respiratory system. If there is cardiorespiratory arrest, you have to make a diagnosis of amniotic fluid embolism. Clear to all of you? Now, so that was postpartum collapse. One question on postpartum collapse you can expect in whatever upcoming exam you are giving. Have you all understood postpartum collapse and how you are going to distinguish? Please remember, in amniotic fluid embolism, always per abdominal examination everything will be normal. On per vaginal examination everything will be normal. Right? Okay. Coming to the next case, and that is algorithm for management of retained placenta. Again, a very important algorithm. These days they are asking questions related to retained placenta, placenta accreta spectrum, and that reminds me, placenta accreta spectrum is a very important topic. So before your INICET exam, please quickly revise placenta accreta spectrum. Okay, now if the question is on retained placenta and your question is saying that the placenta could not be expelled. Now, if the placenta couldn't be expelled, there can be three situations. Number one situation is that the placenta has separated from the uterus, but it is not expelled as the internal os gets closed. This means that it is a case of trapped placenta. And how do I know that it is a case of trapped placenta? Because signs of placental separation will be present. So the signs of placental separation are present, the internal os is closed and the placenta has been trapped inside. So if your question is saying signs of placental separation present and the placenta couldn't be delivered, what is the next step? The next step depends upon whether the uterus is relaxed or whether the uterus is contracted. If uterus is relaxed, I am going to give oxytocin so that uterus contracts and the trapped placenta delivers out. If uterus is contracted and the internal os is closed, so in spite of uterus being contracted, the placenta is trapped inside, then in that case I'm going to go for manual removal of placenta. Second situation is that the question says the placenta is attached to the uterus, it is retained and there are no signs of placental separation, but the placenta doesn't invade the myometrium. In other words, it is not a case of placenta accreta spectrum, it is not a case of trapped placenta. The placenta has not separated till yet, but it is not due to placenta accreta spectrum. In this case, if they ask me the next step, in this case the next step is oxytocin plus controlled cord traction, and if oxytocin and controlled cord traction fail, then the next step becomes manual removal of placenta. So in trapped placenta, you have to check whether whether they are saying the uterus is relaxed or not. In trapped placenta, if uterus was relaxed, the next step is oxytocin. If uterus was contracted, next step was CCT. In case of placenta which has not separated, the next step is oxytocin and controlled contraction, and if it fails, then you go to manual removal of placenta. And in case the placenta invades the myometrium, that means it's a case of placenta accreta spectrum, and all of you know that if it is a case of placenta accreta spectrum, the next step becomes hysterectomy. There is no other option. You have to go for hysterectomy. Right? Clear to all of you? So this is how your next step going to be. Now, if your question says that at any point of time while doing controlled cord traction, the cord breaks and they ask you the next step. So if cord has broken and they ask you the next step is manual removal of placenta. Clear to all of you? Yes? Okay. Then comes another case of obstetrical emergency in which they ask you the algorithm, and again this has to be remembered in the same manner which I am telling you. All these obstetrical emergencies algorithms which I am telling you, you have to remember them in the same sequence in which I am telling you. Whether it is PPH, whether it is uterine inversion, whether it is retained placenta, you have to remember in the same sequence. Now comes management of shoulder dystocia. For management of shoulder dystocia, the acronym which you have to remember is HELPER. So the first step is you have to call for help. The second step is you have to give episiotomy, and E stands for give episiotomy and empty the bladder. L stands for legs maneuver. The leg maneuver which we use is Mac-Roberts maneuver, in which you are going to hyperflex the thighs, and if by doing this the shoulder dystocia is not relieved, the shoulders are not delivered, then the next step is you are going to give suprapubic pressure, and while giving suprapubic pressure you are going to try to deliver the shoulders. Please remember, fundal pressure is contraindicated but suprapubic pressure is given. If this is what is called as, when you are giving suprapubic pressure and you are trying to do the Mac-Roberts maneuver to deliver the shoulder, that is what is called as Rubin 1 maneuver. Right? So if a question comes to you that there is a case of shoulder dystocia and what is the next step, in the options you have suprapubic pressure also, and you have Mac-Roberts maneuver, or you have hyperflex the thigh also as an option, then the first one which you are going to mark will be hyperflex the thigh. Don't say I'm going to give suprapubic pressure first. Suprapubic pressure, if without giving suprapubic pressure you cannot deliver the shoulder, you cannot deliver the shoulders by using Mac-Roberts maneuver, then you have to give suprapubic pressure and do Mac-Roberts again, which is called as Rubin 1 technique. Now, if that also fails, then you are going to go to R, that is remove the posterior arm forcefully. In removing the posterior arm forcefully, then it is E. E is enter and rotate maneuvers, where you are going to use two kinds of rotational maneuvers. One is Wood's corkscrew maneuver, the other one is Rubin 2 technique. The difference between them is that in Rubin 2 technique, you just introduce your two fingers and you try to rotate the shoulders. In case of Wood's corkscrew maneuvers, you introduce two fingers of both the hands and you try to rotate the shoulders, right? So E stands for enter and rotate, that means rotational maneuvers. If that also fails, then you are going to go to the next step, that is R, that is remove the posterior arm of the baby forcefully. This can cause fracture of the arm of the baby, and this is what is called as Jack Mayer's maneuver. If that also fails, you are going to tell the patient to roll on all four limbs, and that is what is called as Gaskin's maneuver. If that also fails, then you are going to go to the last maneuver, which is you are going to push the head of the baby back into the uterus, followed by cesarean section, which is called as Zavanelli's maneuver. In a dead baby, you can fracture the clavicle of the baby, which is called as clidotomy. There is no role of symphysiotomy. Now, each of these maneuvers has to be tried only for 30 seconds. If in 30 seconds that maneuver doesn't fail to resolve shoulder dystocia, it doesn't fail to deliver, if it fails to deliver the shoulders, then you move on to the next maneuver, right? Most common fetal complication of shoulder dystocia is Erb's palsy, and in Erb's palsy, it is C5 and C6 nerve roots which are involved, right? So this HELPER acronym, HELPERR, this is the sequence in which you have to remember the management of shoulder dystocia. You have to remember all the maneuvers which are used for managing shoulder dystocia, right? Then comes case number 11. In case number 11 is a diabetic patient. Now there are 5 tables which are given in Williams for diabetes, and all these 5 tables are very important. So number 1 is criteria for diagnosing diabetes. As far as your NEET exam and FMG exam are concerned, you have to remember only the DIPSI criteria. But for your INICET exam, you have to remember American Diabetes Association criteria for overt diabetes and IADPSG criteria for gestational diabetes. Very, very important. Now, DIPSI criteria, I think all of you know that in DIPSI criteria, what we do in India at the first antenatal visit and then at 24 to 28 weeks, irrespective of previous meals, without any fasting, to all pregnant females, you are going to give 75 grams of glucose in 300 ml of water, and after 2 hours, you are going to check their blood sugar levels. If it is less than 140, that means she is not a case of diabetes. If it is more than equal to 140, gestational diabetes, more than equal to 200, overt diabetes, right? Now, American Diabetes Association criteria for overt diabetes is the same what you do for diabetes mellitus in a non-pregnant female. Fasting blood sugar level more than equal to 126, RBS more than equal to 200, 2-RPP more than equal to 200, HbA1c more than equal to 6.5. Then comes IADPSG criteria for gestational diabetes. According to this criteria, the screening test has to be done at 24 to 28 weeks. Fasting is needed and 8 to 10 hours of fasting is needed. After 8 to 10 hours of fasting, we have to check the fasting blood sugar levels. Then you are going to give 75 grams of glucose and you are going to check 1-RPP and 2-RPP values. That is why it is called as 75 grams 2 hours GTT. Right? Now here the upper limit is something which is different. Now here the upper limit for fasting blood sugar is not 95. Many of you think it is 95. It is more than equal to 92. 1-RPP 180, 2-RPP 153. If any of these values is abnormal, even if one or more than one value is abnormal, then you diagnose it as a case of gestational diabetes. Right? The other important table which is given in Williams is the metabolic goals. So if your patient of diabetes, whether she is on insulin or whether she is on diet modification, what are the goals which should be met? Fasting blood sugar should be less than 95. Pre-meal should be less than 100. 1-RPP less than 140. 2-RPP less than 120. Mean or average capillary glucose values less than 100 and HbA1c less than 6%. Very, very important, right? Now, third important thing which you have to remember is when do you have to terminate pregnancy in case of diabetes. So, in case of diabetes, when it is gestational diabetes, it is called as type A diabetes. It could be A1, A2. A1 means a gestational diabetes which is controlled on diet. A2 means a gestational diabetes patient who is using either insulin or she is using any oral hypoglycemic drug. So A1 GDM में the termination of pregnancy has to be done at 39 weeks. It is between 39 to 41 weeks, right? A2 GDM में, if it is well controlled A2 GDM, again 39 weeks. So it is between 39 to 40 weeks. And if it is not well controlled, then 37 to 38 weeks plus 6 days. Right? Pre-gestational diabetes may 39 weeks. Now, I am just telling you, see, this is something which you have to remember. But I am telling you a trick for all those cases where you have forgotten at what time to terminate pregnancy. So, in all those cases which are controlled cases, which are, for example, if it is a case of controlled diabetes, whether it is controlled on diet, whether it is controlled on insulin, if it is a case of, controlled conditions, in all controlled conditions, the termination of pregnancy should be done at 39 weeks. And whenever it is a complicated condition, it should be done between 37 to 38 weeks. Clear to all of you? Yes? Now, this is a table which is given for management of diabetic ketoacidosis during pregnancy. So, all those who are preparing for your upcoming INICET exam, I want you to take a screenshot of this and just keep it with you. Just go through it once and you will, know how to manage diabetic ketoacidosis in pregnancy. You know how to manage diabetic ketoacidosis in a non-pregnant female. In pregnancy, just look at the relevant changes and keep it with you. Right? This is a very important table again. So these were the important tables which were given in diabetes. And yes, this table over here, insulin management for labor induction or scheduled cesarean delivery. This is a table on which question had come in last year INICET exam. So whenever you are scheduling induction of labor, then one evening before that you are going to give the dose of insulin, right? But in the morning hours you are going to withhold the dose of insulin. You are going to start infusing normal saline at a rate of 100 to 125 ml per hour. And in that normal saline, you are going to add regular insulin. How much regular insulin? 1 to 1.25 units per hour if blood glucose levels go more than 100. So if blood glucose levels go more than 100, then you have to add regular insulin and you have to keep on monitoring her blood glucose levels after every hour. Now, if during active labor, you have to remember that during active labor, you have to change from IV saline to 5% dextrose and your target glucose levels again are around 100. So it is during active labor that I'm going to change from IV normal saline to 5% dextrose. When I'm inducing, I'm giving normal saline and I'm adding insulin only if blood glucose levels go more than 100 milligrams per TL. Clear? So this table there was a question in INICET last year. Then comes preterm labor. This is next case and that is of preterm labor. In preterm labor, an important update is that ACOG recommends that in all pregnant females with history of preterm labor, you have to do a TVS for cervical length measurement between 16 to 24 weeks of pregnancy. Right? So this is a very, very important update that in all pregnant females with previous history of preterm labor, you have to do a TVS between 16 to 24 weeks of pregnancy. So suppose a question comes to you that there is a pregnant female who has previous history of preterm labor and she is presenting to you at 18 weeks of pregnancy for routine examination, routine checkup. What is the next step? Now, because she has previous history of preterm labor, I have to do a TVS for cervical length measurement. And along with that, because there is previous history of preterm labor, to prevent preterm labor from happening, I'm going to give progesterone. So your next step is going to be you have to measure TVS and give progesterone. Right? You have to do a TVS and give progesterone. On TVS, I have to measure cervical length. Now, if cervical length comes out to be less than 2.5 centimeters, and if it is a case of singleton pregnancy, then I have to put a cervical cerclage and I have to continue giving progesterone. So very, very important, the conditions of indications for doing cervical cerclage in preterm labor. The ACOG says that you are going to do cervical cerclage only if your patient has history of preterm labor, number one. Number two, on TVS, when the cervical length comes out to be less than equal to 2.5 centimeters, and number three, she is carrying a singleton pregnancy. Right? Only if all these three conditions are fulfilled, then you have to do a cervical cerclage. Is that clear to all of you? So if your question says that, it is a case of multifetal pregnancy. So there is a pregnant female with multifetal pregnancy who has come to you at 18 weeks and her cervical length is 2 centimeters. On TVS, what is the next step? So do not say that the next step is I am going to apply cervical cerclage and give progesterone. Cervical cerclage is not to be put if it is a case of multifetal pregnancy. Cervical cerclage has to be put only if it is a case of singleton pregnancy. Right? So then you are, in that case, in case of multifetal pregnancy, your answer is going to be that the next step is progesterone. Right? In all case, patients with previous history of preterm labor, irrespective of cervical length, you have to give progesterone. So suppose your question says this particular question that there is a pregnant female who is coming to you at 18 weeks on TVS, her cervical length is more than equal to 2.5 centimeters. What is the next step? So the next step is you are going to continue her progesterone till 36 weeks of pregnancy. Right? Progesterone you have to give irrespective of cervical length if there is previous history of preterm labor. But cervical cerclage you have to do only if there is previous history of preterm labor, only if cervical length is less than equal to 2.5 centimeters and only if it is a case of singleton pregnancy. All these three conditions, if they are fulfilled, then only you have to do a cervical cerclage. Next case, suppose if your question comes that there is a preemie at 16 weeks of pregnancy, on routine ultrasound her cervical length is 2 centimeters. So and they ask you what is the next step. Now this patient doesn't have any previous history of preterm labor. Because she doesn't have any previous history of preterm labor, I will not say that the next step is cervical cerclage, or I will not so in this case, because cervical length is 2 centimeters, in other words, there is a risk factor for preterm labor. So my next step becomes progesterone. Whenever there is a risk factor for preterm labor, your next step is progesterone. Right? So over here, it is an incidental finding on ultrasound that the cervical length is 2 centimeters. She doesn't have any previous history of preterm labor. My next step becomes progesterone. Do not say cervical cerclage. Similarly, if your question says that there is a G2P1 female with previous history of preterm labor, on TVS cervical length is 2.8 centimeters, which means it is above the cutoff value for predicting preterm labor. The cutoff value for predicting preterm labor is 2.5 centimeters, and over here they are saying 2.8 centimeters, and they ask you what is the next step. So over here again, your next step cannot be cervical cerclage, because cervical cerclage has to be done only if cervical length is 2.5 centimeters. But because she has previous history of preterm labor, which is a risk factor for preterm labor, my next step again becomes progesterone. Clear to all of you? Yes. Now another update related to preterm labor's definition. The new definition for preterm labor is if a female is having uterine contractions at less than 37 weeks plus progressive dilatation and progressive effacement, or if a pregnant female is having uterine contractions at less than 37 weeks plus the dilatation of the cervix at the time of presentation is more than equal to 2 centimeters. Right? So this is the new definition for preterm labor, which says that the dilatation, if it is more than equal to 2 centimeters at the time of initial presentation, or if there is progressive dilatation and progressive effacement along with uterine contractions, that is preterm labor. The conventional definition told you that uterine contractions, if they are present with any one of the following, uterine contractions, how many? 4 in 20 minutes or 8 in 60 minutes with any one of the following: cervical length less than equal to 2 centimeters, dilatation more than equal to 3 centimeters, and fetal fibronectin protein present in cervicovaginal secretions. Please remember that the length of the cervix to predict preterm labor is 2.5 centimeters. This is for prediction of preterm labor. To diagnose preterm labor, it is 2 centimeters. Right? The other thing, earlier they said if cervical dilatation was more than equal to 3 centimeters, then it was preterm labor. Now they say if cervical dilatation is more than equal to 2 centimeters, then it is preterm labor. Clear to all of you? Yes. Then a very important table for all of you is management of PROM and management of PPROM, that is premature rupture of membranes and preterm premature rupture of membranes. Now this table is very important in Williams, and again many questions are asked from this table in your INICET exam. Now in order to simplify this table for you, I have made it like this over here. So all questions where you get ruptured membranes, you have to see whether they are talking about premature rupture of membranes or whether they are talking about preterm premature rupture of membranes. Premature rupture of membranes, or PROM, which is also called as pre-labor rupture of membranes, means when the membranes are ruptured at more than equal to 37 weeks. And preterm premature rupture of membrane means when they are ruptured at less than 37 weeks. Again, I am dividing it into two categories, into early PPROM and late PPROM. Late PPROM means when PPROM is happening between 34 to 36 weeks plus 6 days, and early means when it is happening at less than 34 weeks. Right? Now, first thing is induction of labor. In which case out of these three cases am I going to do induction of labor? Now, in a patient in whom membranes are ruptured after 37 weeks, the lungs of the baby are already mature, right? And I do not want to put my patient at risk of chorioamnionitis, and that is why if it is a case of PROM, that is case number A, I am going to go for induction of labor. In other two cases, I am not going to induce labor unless and until your question says that patient has fetal distress or there is chorioamnionitis or abruption. If your question is talking about chorioamnionitis or abruption or fetal distress, then in that case also you have to go for induction of labor. But otherwise in PPROM, whether it is early, whether it is late, you do not go for induction of labor. Then comes prophylaxis for GBS. Group B streptococci prophylaxis. Group B streptococci prophylaxis is given in case of PROM only if membranes are ruptured for more than equal to 18 hours, or if during labor patient has fever more than equal to 100.4 degree Fahrenheit. In all cases of PROM, you are not going to give GBS prophylaxis only if membranes are ruptured for more than equal to 18 hours, or if the temperature is more than equal to 100.4 degree Fahrenheit, then you are going to give GBS prophylaxis. Whereas if it is a case of PPROM, whether it is early, whether it is late, you have to give GBS prophylaxis. Third is corticosteroids. In case of PROM, the membranes are rupturing after 37 weeks. Lungs of the baby are already mature, so I am not going to give corticosteroids. In both the other cases, I am going to give corticosteroids. Then tocolytics. Please remember, tocolytics are never given after 34 weeks. And what is the role of tocolytics these days? The only role of tocolytics these days is to buy time for corticosteroids to act, right? So obviously in a case of PROM, if I'm not giving tocolytics, I'm not going to give corticosteroids also. I'm not giving corticosteroids, so I'm not going to give tocolytics also. In case of early PPROM and late PPROM means membranes are rupturing between 34 to 36 weeks, and just now I told you that beyond 34 weeks you never give tocolytics. So in this case also I am not going to give tocolytics. I am going to give tocolytics only if my question says gestational age is less than 34 weeks. As far as tocolytics are concerned, please remember the new update that yes, tocolytic of choice in India is nifedipine, but according to ACOG, if you are giving tocolytics at less than 32 weeks, then the choice is endomethacin. And if you are giving tocolytic between 32 to 34 weeks, then the choice is nifedipine. Right? Why is endomethacin never given beyond 32 weeks? Because it can lead to premature closure of ductus arteriosus. And endomethacin is never given for more than 48 hours. Why? Because it can lead to oligohydramnios. Overall, the general rule is you should never give tocolytics beyond 48 hours. Right? Then comes magnesium sulfate for cerebral palsy. Magnesium sulfate for preventing cerebral palsy for neuroprotection is given only if labor is happening at less than 32 weeks. So you are never going to give it in a case of PROM. You are never going to give it in a case of late PPROM. You are going to give it only in case of early PPROM if it is happening before 32 weeks. So if PPROM is happening before 32 weeks, you have to give magnesium sulfate. Same is in case of preterm labor. In preterm labor, the only difference is preterm labor के patients में you divide them into two categories between 34 to 36 weeks and less than 34 weeks. So in case of preterm labor, you never go for induction of labor. In case of preterm labor, corticosteroids have to be given. So this is corticosteroids. If they ask you corticosteroids, when are you going to give corticosteroids? Corticosteroids you are going to give in both these cases, whether preterm labor is happening at less than 34 weeks or more than 34 weeks. Then tocolytics you are not going to give at more than 34 weeks. Tocolytics you are going to give at less than 32 weeks. Magnesium sulfate you are going to not give them at more than 34 weeks. You are going to give magnesium sulfate at less than 32 weeks. GBS screening and prophylaxis have to be done in all cases of preterm labor, right? So in PROM and preterm labor, two differences you have to remember. One is in PROM, you have to go for induction of labor. Number two, in PROM, you remember please that in PROM, GBS prophylaxis is given only if membranes are ruptured for more than 18 hours or if patient has fever for more than 100.4 degree Fahrenheit. Whereas in preterm labor, you have to give GBS prophylaxis in all cases, and in preterm labor, you never do induction of labor. Clear to all of you? This table is very, very important. I know like this it is difficult to understand. For understanding, you have to build your concepts, and for that you will have to watch the entire marrow videos where I am telling you in slowly, and I'm explaining each and every point to you. Over here I'm just going through the important points and helping you revise the important algorithms and tables. I hope still you are benefiting. Just show me a thumbs up if you are still there with me. Show me a thumbs up if you are there. Now, the next important case is management of GTN. Now, in management of GTN, again, you people have a lot of confusion. Please remember, stage 1 GTN means that GTN which is limited to the uterus. And if they ask you what is the management of stage 1 GTN, management of stage 1 GTN is you have to give single agent drug, and that is methotrexate. Please remember, जब भी हम GTN को treat करते हैं, whenever we are treating GTN and we are giving methotrexate, we give it in the form of multi-dose therapy. In ectopic pregnancy, when you are using methotrexate, you use it as a single dose therapy. In GTN, you give it as a multi-dose therapy. So in stage 1, management is you have to give single agent methotrexate, and if family of the patient is complete, you have to do a hysterectomy. What does stage 1 GTN means? Stage 1 GTN means a GTN which is limited to the uterus. So if your question says GTN is limited to the uterus, and the next step is you have to give single agent drug, that is methotrexate, which is given in the form of multi-dose therapy. And along with that, if patient's family is complete, do a TH. Now, stage 2 GTN means when the GTN has spread to other pelvic organs, right? For example, if it has spread to vagina, adnexa, broad ligament, then it comes under stage 2. Stage 3 means the GTN has spread to lungs. Now, whenever it is a stage 2 or a stage 3 GTN, you have to do a WHO risk score. You have to calculate WHO's risk score. So WHO risk score, how do you calculate WHO's risk score? It is calculated based on number of criteria. If you are a marrow subscriber, you know that I tell you, you don't have to remember this entire table. You simply have to remember if age of the patient is less than 40, it is low risk. More than 40, high risk. If antecedent pregnancy is a molar pregnancy, low risk. If antecedent pregnancy is a term pregnancy, high risk. If interval between previous pregnancy and molar pregnancy is less than 4 months, low risk. More than 12 months, high risk. If initial HCG values are less than 10 to the power of 3, low risk. More than equal to 10 to the power of 5, high risk. If number of metastases are, the sites of metastasis, if the first I'm talking about the size of the tumor. So if size of the tumor is less than 3 centimeters, low risk. If it is more than equal to 5 centimeters, high risk. If the site of metastasis is lungs, no risk at all. If the site is liver or brain, high risk. If the number of metastases are 1 to 4, low risk. If the number of metastases are more than 8, high risk. Right? And if there is no previous history of failed chemotherapeutic drugs in the past, no risk or low risk and if there is history of previous antecedent failed chemotherapeutic drugs, then it is high risk. So you just have to remember low risk and high risk. And low risk and high risk, you just have to take an idea. You don't have to, mug up this table as such. You simply remember the low risk category and remember the high risk category. And whenever you get a question, see whether your patient is coming in low risk or whether your patient is coming in high risk. Now, suppose if they are telling you the score. So if score is given between 0 to 6, that is low risk. And if score is given more than equal to 7, that is high risk. So whenever a question comes on GTN and it is stage 2 or stage 3 of GTN, your question is saying that the cancer has spread to lungs. In that case, look at the score which is given to you. A common mistake which you people do is that the moment you see that the cancer has spread, you say to the lungs, you say that it is a high risk and I am going to give multi-agent chemotherapy. No. If it has spread to the lungs, you have to do the scoring system. If it comes in low risk score, that means score is coming between 0 to 6, you are going to give single agent methotrexate, which you are going to give in the form of multi-dose therapy. But if the score is coming more than equal to 7, then you are going to give multi-drug chemotherapy. Right? Now, if your question says that GTN has metastasized to brain or liver, in that case, do not even go through this trouble of calculating the score, because if the cancer has spread, if the GTN has spread to brain or to liver, that means it is stage 4, and stage 4 ka matlab hai ki you have to give multi-agent chemotherapy irrespective of the score. In that case, don't look at the score at all. In that case, go for multi-agent chemotherapy. Suppose if a question comes to you that there is a case of GTN with previous history of molar pregnancy and the antecedent pregnancy happened at 6 months prior to this GTN. So this molar pregnancy evacuation was done 6 months earlier. Now patient has come to you with GTN and she has brain metastasis. Now, the moment they say brain metastasis, I am not going to calculate any score. Brain metastasis ka matlab hai ki this is high risk GTN, and in that case, my next step becomes I have to give multi-agent chemotherapy. Right? So, you have to give a multi-agent chemotherapy, and please remember, whenever brain is involved, you have to do radiotherapy also. So, it is chemotherapy plus radiotherapy whenever brain is involved. Clear to all of you? Now, similarly, in case of PSTT and ETT. So, if your question says GTN is PSTT or ETT, for PSTT and ETT, no matter what is the stage, you have to do hysterectomy plus you have to give multi-agent chemotherapy. So, hysterectomy along with multi-agent chemotherapy is the management of PSTT and ETT. Clear to all of you? What is the management of molar pregnancy? Management of molar pregnancy, suction evacuation, unless and until in your question it is given that age of the patient is more than 40 years plus her family is complete. So, in that case, your management becomes hysterectomy. Right? But otherwise, it is suction evacuation. Whether you do suction evacuation, whether you do hysterectomy, you have to follow up your patients for 6 months, and during this 6 months pregnancy is contraindicated and you are going to advise them to use oral combined pills. So these are important algorithms which I wanted you to remember for OBS. Now, in gynae, one of the very important algorithm is for atypical uterine bleeding. Now, that is a very commonly asked topic. If they ask you, a patient comes to you with AUB, what is the next step? The next step is going to be TVS, and depending upon the age, it could be urine pregnancy test along with TVS. For example, if it is puberty menorrhagia, again UPT and TVS. If it is reproductive age, UPT and TVS. If it is perimenopausal age, UPT and TVS. But it is postmenopausal, then only TVS. Right? What is the investigation of choice for atypical uterine bleeding? So, for any endometrial lesion, in atypical uterine bleeding, if I am suspecting endometrial lesion, I am going to do endometrial sampling, that is by endometrial biopsy or endometrial aspiration cytology. What is the gold standard method for studying any endometrial lesion? The gold standard investigation for endometrial lesion is fractional curettage and hysteroscopy. Investigation of choice for endometrial lesions is endometrial sampling, but gold standard is fractional curettage and hysteroscopy. Instead of fractional curettage, in your question, dilatation and curettage could also be given. Now, a very important question is, what are the indications for endometrial biopsy? So if your question is talking about reproductive age female, in a reproductive age female, I am going to do urine pregnancy test, I am going to do a TVS. But am I going to do endometrial biopsy? I am going to do endometrial biopsy only if high risk factors for endometrial cancer are present. For example, if your patient has been on tamoxifen, or if you did an ultrasound and endometrial thickness comes out to be more than equal to 12 millimeters. In this case, I am going to do endometrial biopsy or endometrial sampling. Right? In perimenopausal females, our national guidelines say that in all females who are more than equal to 40 years, international guidelines say that all females who are more than equal to 45 years, irrespective of their endometrial thickness, you have to do endometrial biopsy. Irrespective of ultrasound findings, you have to do endometrial biopsy. And that is how they try to confuse you. They will give you a question where they are going to say that there is a female of 45 years of age who has come to you with the 2 into 3 centimeters of a fibroid. Right? On ultrasound, there is a fibroid seen which is 2 into 3 centimeters in size. What is the next step? Now, all of us start thinking about management of fibroid, but we forget that this patient is 45 years of age. At 45 years of age, irrespective of ultrasound findings, the next step is endometrial biopsy. Either in the options endometrial biopsy will be given, or endometrial sampling will be given, or endometrial aspiration cytology will be given. With which instrument in India you do endometrial biopsy? In India, you do endometrial biopsy with Carman's cannula. It is an OPD procedure. Whereas worldwide, special instruments are present for endometrial biopsy, and they are a Vabra aspirator and a Pipel. But in India, we are doing all this with the help of Carman's cannula. Now, what if your question is talking about a postmenopausal female who has come to you with postmenopausal bleeding? Now, again, if a postmenopausal female comes to me with postmenopausal bleeding, as I told you, the next step is TVS. On TVS, I am going to check the endometrial thickness, and if endometrial thickness is more than equal to 4 millimeters. You cannot see it there. That is why I have written at the bottom. If it is more than equal to 4 millimeters, then I am going to do endometrial biopsy. So 3 different age groups, 3 different protocols. In reproductive age female, you are going to do endometrial biopsy if endometrial thickness is more than equal to 12 millimeters. In perimenopausal females, you are going to do it irrespective of endometrial thickness, irrespective of ultrasound findings. And in postmenopausal females, you are going to do it if endometrial thickness is more than equal to 4 millimeters, right? Now, other than this, what are the indications for endometrial biopsy in a postmenopausal female? As I told you, if a postmenopausal female is coming to me with AUB, or she's coming to me with postmenopausal bleeding, and on ultrasound endometrial thickness is more than equal to 4 millimeters, I am going to do endometrial biopsy. In all these cases, along with endometrial biopsy, I am also going to do a pap smear, because cancer cervix is one of the very important causes of postmenopausal bleeding in India, right? But overall, if they ask you what is the most common cause of postmenopausal bleeding, if you get a question like this, normally in INICET and Neet, they do not give you questions like these. But still, if they give you a question like this, your answer is going to be senile endometritis, or your answer is going to be atrophic endometrium, right? Now, suppose if a postmenopausal female comes to you with postmenopausal bleeding, on ultrasound her endometrial thickness is less than 4 millimeters, and they ask you what is the next step. Now, I have to control her bleeding, so to control her bleeding, I am going to give her tranexamic acid. Now, if your question says that in spite of giving tranexamic acid, her bleeding persists, what is the next step? Then the next step is fractional curettage and hysteroscopy. Please do not say endometrial biopsy in this case now, because now I want, in spite of giving treatment, if bleeding is not stopping, in this case, I want to rule out endometrial cancers, and for that, I'm going to do fractional curettage and hysteroscopy. Right? Now, suppose there is a postmenopausal bleeding there is a postmenopausal female who doesn't have any postmenopausal bleeding, but an incidental finding on ultrasound is that endometrial thickness is more than equal to 11 millimeters, or endometrial thickness is more than equal to 4 millimeters plus fluid is seen inside uterine cavity, then that is also an indication for endometrial biopsy, irrespective of the fact that the patient is not bleeding. So postmenopausal female may, if endometrial thickness is more than equal to 11 millimeters and even if she is not bleeding, right? Because in postmenopausal female, I expect endometrium to get atrophied. But in this case, instead of endometrium getting atrophied, I am getting endometrial thickness as more than equal to 11 millimeters. So I am again going to do endometrial biopsy. Then if your question mentions metropathia hemorrhagica, in metropathia hemorrhagica you do endometrial biopsy, and if on pap smear you are getting atypical glandular cells of unknown significance, then you do endometrial biopsy. So these are all indications for doing endometrial biopsy. As I told you, the gold standard for endometrial pathology is not endometrial biopsy, it is fractional curettage and hysteroscopy. What are the indications for fractional curettage and hysteroscopy? If endometrial biopsy report says atypical endometrial hyperplasia, then that is an indication for fractional curettage. If endometrial biopsy report says insufficient tissue, so now if your tissue is coming insufficient, sample is coming insufficient, instead of repeating endometrial biopsy, I will go to the gold standard method, which is fractional curettage. If endometrial biopsy report is normal, but in spite of treatment my patient is continuing to bleed, then I am doing fractional curettage and hysteroscopy. And if there is cervical stenosis, then in that case I will have to dilate the cervix, and if I have to dilate the cervix, then why to go for endometrial biopsy? Go for a better procedure, that is fractional curettage and hysteroscopy. Right? So if the cervix is stenosed, I will have to give her anesthesia, I will have to dilate, then I will go for fractional curettage and hysteroscopy rather than endometrial biopsy. These are all indications for fractional curettage and hysteroscopy, and it is very, very important that all of you know these indications on your tips. Right? Now the next very important question is that endometrial biopsy report has come and they ask you the next step. So if endometrial biopsy report is endometrial hyperplasia without atypical features, if they ask you what is the next step is progesterone, and the drug of choice which you are going to give, either you can give Mirena or you can give oral medroxyprogesterone acetate. Preferable is we give Mirena. When I am giving oral medroxyprogesterone acetate, I can give it either continuously or I can give it intermittently for 12 to 14 days. When my patient is on progesterone, I am going to follow her up after every 3 to 6 months for 1 year by endometrial biopsy. And if in 3 to 6 months, in spite of giving progesterone, patient's endometrial hyperplasia persists, or if her bleeding persists, right, I am giving progesterone, which is an anti-proliferative agent, and in spite of giving progesterone, her endometrial hyperplasia is persisting or her bleeding is persisting, in that case I am suspecting endometrial cancer and I will go for fractional curettage and hysteroscopy. If my report comes as endometrial hyperplasia with atypical features and they ask you the next step is fractional curettage and hysteroscopy to rule out any coexisting endometrial cancer which may be present. Because if endometrial cancer is present, my answer is not a simple hysterectomy. In that case, to the patient, I am not going to do a simple hysterectomy. So before I say that for endometrial hyperplasia with atypical features, before I jump to hysterectomy as the answer, I have to first rule out endometrial cancer, and in order to rule out endometrial cancer, my next step is fractional curettage and hysteroscopy. Very, very important confusing question, because they are going to say endometrial biopsy report shows endometrial hyperplasia with atypical features, and they will ask you the next step. So if they say endometrial hyperplasia with atypical features and they ask you the next step, please do not jump to hysterectomy as the answer. Your answer is next step is fractional curettage and hysteroscopy. Yes, the best step is hysterectomy. Why am I doing fractional curettage and hysteroscopy? To rule out any coexisting endometrial cancer which could be present, right? Now, if your question, case number 17, if your question comes on postmenopausal bleeding, then they ask you the next step. Next step in case of postmenopausal bleeding is TVS, On TVS, if endometrial thickness is less than 4 millimeters, what am I going to do? And patient is bleeding, I'm going to give a tranexamic acid. If symptoms persist, as I told you, then I'm going to go for fractional curettage and hysteroscopy. If endometrial thickness is more than equal to 4 millimeters, I will do endometrial biopsy. If endometrial biopsy report comes out to be normal, or if atypia is absent, but in spite of giving treatment, bleeding is persisting, then again the next step is fractional curettage and hysteroscopy. Right? Now if atypia is present, I told you you have to go for hysterectomy, but if patient refuses, and if patient or refuses, I will have to give her progesterone. And in spite of giving progesterone, in this case her bleeding is persisting. Right? So she says, I don't want to get a hysterectomy done. She is a case of endometrial hyperplasia with atypia. I tell her, please go and get a hysterectomy done. I'm going to do your hysterectomy. And she says, no, I will not do hysterectomy. So I say, okay, I'm going to put you on progesterone. Right? But in spite of giving progesterone, if her bleeding persists, and they ask you the next step, so in case of endometrial hyperplasia with atypia present, do not say that if bleeding persists, next step is fractional curettage and hysteroscopy, because you already have done fractional curettage and hysteroscopy when atypia was present. जैसे ही atypia की report आई थी, हमने immediately fractional curettage and hysteroscopy कर लिया था. Right? So now there is no use of doing fractional curettage and hysteroscopy again. Now your answer is going to be hysterectomy. And that is why all these three things I have written together. PMB का patient है, endometrial thickness less than 4 millimeters है, in spite of giving Tranexa, bleeding is persisting. Next step, fractional curettage and hysteroscopy. Then endometrial thickness more than equal to 4 millimeters थी, endometrial biopsy करी, atypia नहीं आया, there is no atypia. So because there was no atypia, I gave her progesterone, but in spite of giving progesterone, bleeding persists. The next step is fractional curettage and hysteroscopy. Atypia आया report में, I suggested a hysterectomy, she refused. And because patient refused, I gave her progesterone, and in spite of giving progesterone, her bleeding is persisting. Next step. Now next step will not be fractional curettage and hysteroscopy. Now next step is going to be hysterectomy. Clear to all of you? All these next steps are very, very important. Right? I hope all this is clear to all of you. If it is clear, quickly show me a thumbs up. Show me a thumbs up if you've understood, all of you, bachcho. All these next steps are very, very important. Okay. Now, case number 18. Case number 18 is approach for screening in resource limited countries, which has been given by WHO. So WHO says that for screening of cancer cervix, you have two approaches in resource limited countries. Either you can go for a see and treat approach, or see triage and treat approach. In see and treat approach, the primary screening test is HPV DNA. That is the first choice which has been given by WHO. And if HPV DNA is not available, then VIA. And see and treat approach means that you have to do a screening test. If screening test is positive, based on the result of screening test, you do the treatment. Treatment can be ablation or LEEP. Right? If screening test is negative, then you have to repeat HPV DNA after every 5 to 10 years in general population, after every 3 to 5 years in HIV positive females, and VIA if you are doing, then after every 3 years you have to repeat VIA if screening comes out to be negative. Now, whenever, see, in what ACOG says, and what we've always done is, कि pap smear की report के बाद you can never do the treatment. After pap smear report, you do a biopsy, and based on biopsy, whether it is CIN1, CIN2 or CIN3, then you go for treatment. And I tell you that CIN2 and CIN3 are managed with LEEP. Now here WHO is saying there is no need to do a biopsy. Just do a screening test, and if screening test comes out to be positive, then you do the treatment, which could either be ablation or LEEP. So how is WHO deciding? And based on WHO's protocol, how am I going to decide whether I have to do ablation or LEEP? So that WHO says if entire transformation zone is visible on exocervix, if you can see the entire transformation zone on exocervix, in other words, the transformation zone is not extending to endocervix, and if your patient is HIV negative, in this case you have to go for ablation. If transformation zone is extending into endocervix, right, or if entire transformation zone cannot be seen clearly, or if your patient is HIV positive, then you have to go for LEEP, right? This is its see and treat approach. Then comes see, triage and treat approach. In see, triage and treat approach, WHO says that you have to do a primary screening test. If it comes out to be positive, this has to be followed either by a secondary screening test or a diagnostic test. And if it comes out to be positive, then you have to do the treatment, right? So for see, triage and treat approach, the primary screening test which has been recommended by WHO is HPV DNA. And if HPV DNA comes out to be negative, then in that case I don't have to do anything. If it comes out to be negative, then I have to repeat HPV DNA testing in general population after every 5 to 10 years, and in HIV positive females after every 3 to 5 years. Now if HPV DNA comes out to be positive, then in that case I have to do a triage. That means I have to do a secondary screening test. The secondary screening test which is most oftenly recommended by WHO is VIA. But other than VIA, you can do HPV genotyping, or you can do pap smear or colposcopy. Now, WHO says that if you have done HPV genotyping, VIA or colposcopy, and if any of these come out to be positive, then straight away go to the treatment. But if you, as a secondary screening test also, if you have chosen pap smear, and if pap smear comes out to be positive, based on pap smear report, you never do the treatment. So if pap smear report comes out to be positive, you will have to follow it up with colposcopy. You cannot say I'm going to do treatment. So according to WHO, for see, triage and treat approach, the first test which you do is HPV DNA testing. If it comes out to be positive, you do a second test. The one which is recommended is VIA. Right? But you may do colposcopy, you may do pap smear, you may do HPV genotyping. Now, if VIA also comes out to be positive, then you do the treatment. Now, suppose primary screening test was negative, and they ask you after how many years are you going to repeat HPV DNA testing. Then according to WHO, you in general population you have to repeat it after every 5 to 10 years. In HIV positive you have to repeat every 3 to 5 years. But suppose HPV DNA was positive but secondary screening test is negative, right? VIA is negative. A VIA negative hai to I cannot do the treatment. Right, so now in this case, after how many years should I repeat HPV DNA testing? In this case, I should repeat HPV DNA testing after every 2 years in general population and after every 1 year in HIV positive females. Now, there are HPV vaccines available, all of you know that. For HPV vaccine, please remember there are SAGE guidelines for HPV vaccine. A question on SAGE guidelines for HPV vaccine was asked in your previous INICET and Neet exam. Go to the recall and please watch SAGE guidelines, WHO SAGE guidelines for HPV vaccine. Very, very important. Now, according to WHO, this is again a new update which is there. According to WHO, when should you start screening for cancer cervix in general population? 30 years. In a female who's living with HIV positive HIV positive partner, 25 years. Then target population is 30 to 49 years. The age to stop screening is 50 years. According to ACOG, जो अभी तक हम पढ़ते थे, according to ACOG, Screening began at 25 years and it ended at 65 years. But according to WHO, screening is beginning at 30 years and it is ending at 50 years. Target population is 30 to 49 years. According to WHO, see triage and treat approach is better than see and treat approach, and that is why the best screening test is HPV plus VIA. If HPV plus VIA is not given in the options, then only HPV, and if only HPV DNA is not given, then VIA. Clear to all of you? Yes. Then report of pap smear and next step. This is a very commonly asked question in INICET. They will give you a report of pap smear and they are going to ask you what is the next step. So when it is a case of all these next steps I have written here, whether it is the report says ASCUS, whether it says LSIL, if it says HSIL, if it says ASCH, then what you should do. If the pap smear report says HSIL or if the pap smear report says ASCH, whenever this word H is there, HSIL means high squamous intraepithelial lesions, ASCH means atypical squamous cells where HSIL cannot be ruled out. And they ask you the next step, irrespective of age of the patient. Next step is colposcopy plus endocervical curettage. Now, if report is LSIL, if your report is LSIL, see the age of the patient. If age of the patient is less than 25 years, repeat pap smear. If age of the patient is more than 25 years, go for a colposcopy or a colpo biopsy. Either in the options colposcopy will be written or colposcopic directed biopsy will be written or colpo biopsy will be written. Right. Now, if report comes as ASCUS, ASCUS means atypical squamous cells of unknown significance. So the pathologist says, I do not know the significance of these cells. Then again, look at the age of the patient. If age of the patient is less than 25 years, you are going to repeat pap smear after an year. If age of the patient is more than 25 years, the next step is HPV DNA testing. Whenever you do HPV DNA testing after an abnormal pap smear report, it is called as a reflex test. Right? Now, if report comes as atypical glandular cells of unknown significance and they ask you the next step, these glandular cells or columnar cells, either they could be belonging to endocervix. So my next step is endocervical curettage. My next step is colposcopy, or it could be that it is an endometrial cancer which has come into the cervix. Right? It means it is a stage 2 adenocarcinoma of the endometrium. Right? So in that case, I will also have to do endometrial biopsy. So whenever I am getting atypical glandular cells of unknown significance, I have to rule out cancer cervix, the adenocarcinoma of the cervix, and I have to also rule out adenocarcinoma of endometrium, and that is why these 3 investigations you have to do. Now suppose your question says that in a patient in whom pap smear report showed AGUS, endocervical curettage shows adenocarcinoma in situ, what is the next step? Now, if your endocervical curettage report is showing adenocarcinoma in situ and they ask you the next step is cone biopsy. Why am I doing cone biopsy? I am doing cone biopsy to rule out any existing cancer cervix which may be present, invasive cancer which may be present. So because if invasive cancer is present, then my management is not a simple hysterectomy, right? So my next step is cone biopsy, and if no invasive cancer is present, then the management becomes hysterectomy, a simple hysterectomy. Right? Now, if your question says colposcopy was done and the report shows CIN1, what is the next step? Next step is you have to follow up the patient for 2 years. Even after 2 years, if CIN persists, then you are going to go for cryoablation. And if it is a case of CIN2 or CIN3, your question is saying that on colposcopy CIN2 or CIN3 is present, then no matter what age they give you, no matter what parity they give you, management is LEEP or LLETZ, large loop excision of transformation zone, or LEEP. In case of CIN2 and CIN3, or in case of any CIN, hysterectomy is not done. CIN2 and CIN3 का management is LEAP or LETZ, irrespective of the age of the patient, irrespective of the parity of the patient. Right? Next and the last case which I want to discuss with you is postcoital bleeding. So if question comes that there is a female who has come to you with postcoital bleeding, what is the next step? Next step is per speculum examination, and after a per speculum examination, I am going to do a pap smear. Per speculum examination is done to rule out other causes of postcoital bleeding like ectropion, like a polyp. Right? If your question says that there is a female who has come to you with postcoital bleeding and on per speculum examination cervix is normal, and they ask you what is the next step, then cervix is normal and next step again is pap smear. Now, if question says on per speculum examination growth is present and they ask you the next step, then the next step is punch biopsy. If question says on per speculum examination cervix is barrel shaped, it is thick, indurated or it is firm, these are physical examination findings of cancer cervix. Then next step is colposcopy. So colposcopy or colposcopic directed biopsy, that's one and the same thing, right? So can you see that small change in the information in your question can change your answers, right? Then now coming to some updates which I want to give you. The first update which you have to know is about WHO's labor care guide. This is the next generation partogram which has come, and in this next generation partogram, please remember that active phase begins at 5 centimeters. In modified WHO partogram, active phase began at 4 centimeters. So now active phase begins at 5 centimeters. In this new partogram, there is no alert line, no action line, right? And according to this partogram, in active phase, dilatation of the cervix could be less than 1 centimeter per hour. And because dilatation of the cervix could be less than 1 centimeter per hour, so obviously you cannot draw any alert line. Alert line was based on the fact that dilatation of the cervix in active phase is 1 centimeter per hour. Right now, because this criteria is no longer there, so no alert line is there, no action line is there. There are time-based cutoffs for each centimeters of dilatation. The other very important thing is in the earlier partogram which we studied, the modified WHO partogram, we did not represent the second stage of labor. In this case, second stage of labor is represented on partogram. Third important thing is whenever a female will start pushing in the second stage, you are going to write P there. Then there is a new section which is supportive care section. In the supportive care section, we are going to mention about pain relief. That is, for pain relief, what we have given, how much oral fluid patient has taken, which was earlier not mentioned, right? In which posture patient has delivered and who is the companion. Now, in the earlier partogram, uterine contractions were represented, the duration and the frequency was represented, and even the strength was written if the strength of contractions was monitored. In the new generation partogram or the next generation partogram, for uterine contractions, only duration and frequency is mentioned. Strength is not mentioned. I hope you remember from modified WHO partogram that each box in uterine contraction represents the number of contractions which happens in 10 minutes. So you are going to put your hand for 10 minutes and you are going to note the number of contractions. If 3 contractions occur, you are going to color 3 boxes. So each box represents 1 contraction. The way in which you color the box tells you about for how long the contraction stayed. So if you make dots, that means the contraction lasted for less than 40 seconds. So all these things are still there. The only thing is that strength is not to be mentioned. Earlier also in modified WHO partogram, there was provision of mentioning the strength. It was not mandatory that you measure the strength of the uterine contractions, right? Clear to all of you? The important differences are that now second stage of labor is being monitored. Now active phase by WHO is beginning at 5 centimeters. In other words, plotting is going to begin at 5 centimeters, and a new section of supportive care has been included, which includes pain relief, how much orally the patient is taking, what posture she is adopting, and which companion is along with her during the process of labor. Right? So this over here is difference between modified WHO partogram and WHO's labor care guide. All this is there on my Instagram handle also. If you want, you can go through them again from there. Right? Then Lakshya, that is Labor Room Quality Improvement Initiative, which came in 2017. Some important do's and don'ts related to Lakshya, again I have given them on my Instagram handle, or you can take a screenshot, and this is again very important, and this is an update which you should be aware of. Next important thing is there is an update on semen analysis. Now 2021 May WHO has given a new criteria for semen analysis. All of you should be well versed with this new criteria of semen analysis. Again, as you always know that in semen analysis, it is the minimum which is given for conception. Whenever WHO gives parameters for semen analysis, it doesn't ever give you the average parameters, right? It tells you minimum how much is needed for conception. It tells you the 5th percentile. Right? So now WHO has changed this minimum criteria needed for conception, and now this is a little lower than what it originally was. That is one difference. All these parameters are little bit relaxed now, and they are lower than what they were earlier given in 2010. And number two difference is one more parameter is included, and that is semen odor. And if your patient's semen has an odor of urine or it has a putrefactive odor, then that is clinically important. Next important difference is now in sperm, motility is divided into 4 categories: A, B, C and D. Grade A means fast progressive motility, grade B means slowly progressive motility, grade C means non-progressive motility, and grade D means immotile sperms. Right? Now, whenever we are talking about progressive motility in semen analysis, we are talking about both A and B, fast progressive motility and slow progressive motility. So now look at the differences. Earlier, the minimum semen volume which was told was normal is 1.5 ml. Now it says 1.4 ml. Total sperm count, earlier it was given 39 million per ejaculate. Now also it is 39 million per ejaculate. Right? Total motility, earlier it was 40% should be the total motility. Now it is 42% should be the total motility. Progressive motility 32%. Now progressive motility is reduced to 30%. Right? Progressive motility, as I told you, includes grade A and grade B. Non-progressive motility 1%. Immotile sperms 20%. Earlier immotile sperm was 22%. Vitality. Vitality, earlier it was said 58% sperms should be living. They should be vitality was 58%, which was taken as minimum. Now minimum vitality is taken as 54%. Morphology remains the same. Morphology, earlier it was also that 4% should be morphologically normal sperms according to the strict Tigerberg criteria. Now also it is 4%. So the differences which you have to remember are in semen volume, you have to remember in total motility, in progressive motility, and in vitality. These are 4 things which you have to remember. Semen volume, now it is 1.4 ml. Total motility now is 42%. Progressive motility now is 30%. Earlier it was 32, now it is 30. And vitality is 54%. I want all of you to note down these things in your 20th notebook. Very, very important recent WHO parameters for semen analysis. Again, say everything rest is same. If they ask you which is the most important semen analysis parameter, still it is morphology. The most important parameter is morphology, followed by motility, followed by concentration. Right? In which conditions do you get azoospermia? In 2 very important conditions you get azoospermia. One is Klinefelter syndrome and the other is cystic fibrosis. Right? What is the best investigation which can help you in knowing azoospermia is pretesticular, testicular or obstructive? FSH levels. Right? So these are important questions and important updates. One more important update is regarding India's first quadrivalent HPV vaccine. India's first quadrivalent HPV vaccine, Sarvavac vaccine, is being manufactured by Serum Institute of India, that is in Pune. And this Sarvavac vaccine is a quadrivalent vaccine which is active against HPV 6, 11, 16 and 18. Right? So these are all the updates which I want to give you. Please keep going because you didn't come this far to come only this far. All of you have worked very hard. All of you have, tried your best up till this time. Now is not the time that you have to quit. You don't have to quit just now. You have to keep working and you have to, fulfill your dreams. You have to fulfill your parents' dreams. All the best for your upcoming INICET exam. Once your exams are over, please post to me on my Instagram handle what questions came so that I can discuss a recall with you. Now, any questions which you have, now you can send it to me in the live chat and I will be happy to answer them now. I'm just waiting that if you have any questions, now I'll answer them. I know it was a lengthy session. It was lengthy for me also, but there was so much which I wanted to share with you and we had less time. PDF, I am actually very bad technically. So I will not be able to provide PDFs to you. You all can take screenshots and keep it with you. Kunj Talod wala, don't worry about FMG exams. I'm taking your revision sessions and in those revision sessions I will be covering all important updates with you people. If overall drug of choice for PPH is asked, then it is carboprost. First line drug is oxytocin, but drug of choice is carboprost. Any other question? No other question? Okay, so let's end this session here now. All the best to all of you. Keep revising and please sleep well before your exams. Do not panic. You all have prepared very well. God bless you all. Take care. All the best.